Hernias. What exactly is a hernia? Different types of hernias, and what, from a clinical standpoint, is it that we are looking for as clinicians? So a hernia essentially is an outpouching of the contents that are contained within a barrier. The most common types of hernias that people are familiar with are hernias which occur in the groin, the inguinal region. The different types of hernias in that region are referred to as inguinal hernias, be it direct or indirect, and femoral hernias. There is some speculation that inguinal hernias, indirect and direct, can be delineated in a clinical setting. The opinion from small bowel surgeons, for the most part of it, is that the only way to definitively differentiate between these two is by means of surgery. Other types of hernias in the abdominal wall include hernias around the umbilicus and umbilical hernias themselves. Umbilical hernias are in fact a congenital issue, therefore you are born with it. True umbilical hernias affect females more so than males. The majority of umbilical hernias that we see in a clinical setting are in fact para-umbilical. Other hernias include hernias in the epigastric region, which is just the region directly beneath the sternum, the xipha process where the ribs meet here, that region there, what we refer to as the epigastrium. You've got the hiatus hernia, which is a hernia that we cannot see clinically. It's usually suspected through the symptoms that the patient experiences, and hiatus hernia essentially is an outpouching of the stomach through the diaphragm and an aperture through that. So it's not something we see because it's then inside the thoracic cavity, inside the lung, inside the rib cage. So it's not palpable. And then there are incisional hernias, which occur at a site of surgery, for example, where you have an incision due to surgical procedure, and then that leaves an element of that wall a little weaker than it should be otherwise. So let's understand what we mean by an outpouching. So we've got the abdominal wall. Appreciate that we have 3 layers of muscle, the abdominis internus, abdominis externus, and the transverse abdominis. And then on top of all these 3 layers, we've got the superficial rectus abdominis. When you have a weakening in any part of that wall, the viscera, the gut, or some of the mesenteric fat may actually protrude through that little weakening. When would that happen? Well, that would happen, generally speaking, when we exert to the point we increase intra-abdominal pressure. So, for example, coughing, sneezing, bearing down. These are known as Valsalva maneuvers. Amongst these 3 other factors that include or predispose a patient or an individual to actually experiencing or having a hernia include age, because of the natural weakness that occurs as a result of the aging process, a chronic cough, for example, chronic constipation due to the excessive amounts of bearing down, as well as a history of herniations. Symptoms-wise, a patient can experience experience some pain and aching sensation, particularly during exertion. You can have a discomfort in the gut itself, or otherwise it can be more aesthetic, appearing as a lump that, again, like I say, is palpable on exertion. And this very much is the way how we examine a patient to determine whether or not the lump that they are presenting with is a hernia or otherwise. Appreciating different types of hernias. Femoral hernias occur mostly in females. The inguinal hernias usually occur on the right-hand side, so a good 60% of hernias, inguinal hernias occur on the right-hand side, 40% occur on the left, and 20% occur on both sides. These are known, the last one, the one that occurs on both sides, is also known as the pantaloon hernias. The challenge we have with hernias, or the concern we have with hernias, is that the protrusion that is, if the outparching that is, if that becomes incarcerated, which essentially means it becomes squeezed to a point that the blood supply to the area, to the viscera, to the organ, whatever might be, the gut that's pushing through, the blood supply then reduces and it is cut off. If that happens, that will lead to strangulation. Strangulation will in essence lead to gangrene, necrosis of the area, and therefore also small bowel perforation. These are significant complications. They require immediate surgery, and in most circumstances, the area that's affected requires removal. So we end up, the patient ends up having to undergo significant surgical intervention to have what we call small bowel resection. That usually will lead to insertion of a stoma bag. Not exactly what we want. So as clinicians in primary care, secondary care, what are we looking for? We're looking for whether the site of the hernia, first and foremost, is it a hernia? Secondly, we want to try and understand the cause of the hernia, so the type. And then we are looking for redness, swelling, and pain over the actual site. That would suggest there is perhaps an element of infection or otherwise. The next thing we look, which is very important, is reducibility. Can we push the protrusion back through the wall? Important note here is the aperture through which the protrusion occurs. Usually, one would expect the smaller the aperture, the safer it is. In fact, if you think about it, the smaller the aperture, the greater the risk of strangulation. So, in all honesty, or in reality, the larger the aperture, the less chance of strangulation or incarceration and then strangulation. The highest risk of strangulation is your femoral hernias, followed by the indirect inguinal hernia, and then another hernia known as the obturator hernia. The incisional hernias usually have a wide neck, so the aperture is usually large. So they are the ones that normally will actually protrude largest. So the bigger the hernia, usually it's a bigger aperture, and therefore it's actually safer in terms of complications. Reducibility, as I was saying, can we push the hernia back through, and therefore is it in that case it is reducible? That's a good sign. If a hernia is not reducible, that then leaves us concerned, because you then, again, like I said, the complication of incarceration, strangulation, necrosis, gangrene, and so on and so forth. Final point I'm going to add here is we appreciate hernias in the context of the abdominal wall, as I've just given here. But there are disc herniations also. So the intervertebral discs in the spine, what's known commonly amongst the general population as a slipped disc or a bulging disc. This is also a herniation. The intervertebral disc has two layers: the inner liquid center, the nucleus pulposus, and the outer fibrotic layer, made up of 25 layers of crisscross concentric circles. This is your annulus fibrosus. If you have a weakening in the annulus fibrosus, the outer layer, when we exert in the various motions that we place the body in, so for example bending down, bending backwards, arching the back, etc., and then we put a load on that, that will allow the nucleus pulposus, the liquid center on the inside, to push through that weakening. And if that force is sufficient and significant, it will actually cause deformation of the actual nucleus, the annulus fibrosus. That will then manifest itself as a disc bulge, what we call a disc herniation. So hernias are not confined to the abdominal wall. They occur throughout the body. It's just that we don't necessarily refer to them, or we don't necessarily appreciate them in the same context. But appreciate that any weakening in the wall or the container of the contents that are contained within it, and if you increase the pressure in that region, that can then cause the herniation. Thank you for watching.